All right. Good morning, everyone. Thank you so much for joining. I am so excited to get ready. In just about 5 minutes, we will start. If you don't mind opening up your chat box, saying hello and where you are logging in from, I want this session to be very interactive. So let's go ahead and open up your chat box. Make sure you change your setting to from panelist to everyone so that we can all engage in the chat box. Awesome. I see some people from New York, Boston, New Jersey. All right. Excellent. Arizona, Carla, Puerto Rico. Wonderful. Well, thank you all for joining. We're going to get started in just a little bit. Please go ahead and get settled, and it will be a jam-packed 1-hour review. All right, before we go ahead and get started, if you are able to say hello in the chat box, do you mind just typing in yes if you can see me, hear me, and see my slides? Go ahead and type in yes. Wonderful. Great. We're also streaming this live on YouTube, so please make sure you tune in. I'm going to just share the link in the chat box right now. Make sure you share it to social media or to your friends who are in the library with you studying. This is going to be an awesome review and very high yield, something different than what we've been doing in the past few months. Thanks so much, Anoop. Actually, I'm on my third cup of coffee. So usually I have to stay pretty well caffeinated to balance clinical and teaching. I love that. Thank you. All right. If you're just joining us, please go ahead and say hello in the chat box and where you're logging in from. We're going to get started soon, but I really want to bring the energy into today's classroom. So if you haven't already, please go ahead and change your setting in your chat box to everyone. And please say hello and where you're logging in from. All right. Jennifer from Toronto, Vanessa from Puerto Rico. Wonderful. Siddharth, Sandy Springs, Georgia. I'm in Georgia right now too. Cool. All right. Charmy from India, international audience. This is awesome. Wonderful. Excellent. So it is 10 o'clock Eastern time, and I want to be very respectful to all of yours time. I am so thankful that you can join me this morning for just 1 hour of preparation. And this is going to be a very high yield review. What I ended up doing in this review is take all of the biochemical pathways and I parsed out all the high yield syndromes that they ask you. And why is that? Well, this is going to be a primer for my live class next weekend, 2-day course, which I'm going to give you details as we go through this introduction. But I am going to link the Zoom link for you to sign up right into the chat box. So make sure you're looking at the chat box right now. Please consider signing up because this is going to be such a high yield review, ton of value, ton of courses coming right at you. So for many of you who do not know me, my name is Rahul, and I'm currently in my final year of pediatric critical care fellowship. Over the past 6 years, I've been absolutely passionate about helping students just like you kick ass for on the USMLE exam. And my goal is really to augment your content, your integration, and your test taking strategy. And that's why a lot of my courses have been designed to just bring private tutoring straight to the comfort of your study space. Now, what makes my preparation program so unique? Well, I like to have a very personalized approach that is rooted in active recall. And as you may have checked out my prior videos or you're enrolled in my courses, I teach each system in a question-based manner. I also like to integrate across concepts, and this webinar is going to be a great example of integrating concepts together. We are going to be going through syndromes which affect, as we will see, many different organ systems, and this is going to be a great nidus for integration. I mean, come on, we're going to be talking about Ehler's Danlos, connective tissue defect, mitral valve prolapse, and yes, decreased preload, making the murmur louder. I mean, that is going to be a phenomenal integration. And then finally, I have created the only course which teaches you how to apply the material which you're studying in a systematic approach. I have courses on how to create a study schedule, as well as courses on how to augment your NBME scores by becoming a better test taker. So please check that out on my website, highguru.com. As you know, biochemistry is absolutely high yield for the USMLE. I mean, it comprises of about 15% of the exam. And this webinar today is going to be a primer for next weekend's review, November 6th and 7th, from 10 a.m. to 1 p.m. each day. It is going to be a live classroom review that goes through the highest yield biochemistry metabolic pathways in a question-based integrative manner. Now, I would encourage each and every one of you to sign up for this live course. And why is that? Well, you're going to be getting tons of valuable content. Not only are you going to have 6 hours of live Zoom content, you're going to have the recording. You're also going to get enrollment into my USMLE Rapid Review course, my most popular course. If you sign up for this, you get complimentary access to this course. And this course has really been a game changer for students who are preparing for the exam, who are maybe plateauing on their NBME practice scores or need a quick rapid review a week before their exam. This is going to be a phenomenal addition to your preparation. So what are we going to cover in next weekend's course? And again, I'm going to just link that into the chat box so that you can check out the link. We will be covering all of metabolism in a question-based manner. But what I'm going to do is I'm going to take metabolic pathways and I am going to take it one step beyond and tie it to organ system pathology. So what we're going to do is, for example, in hematology, we are going to be talking about the normal pentose phosphate pathway, and then I'm going to integrate G6PD deficiency. Or, for example, when we are going to be talking about neurology, I am going to be integrating how the brain is going to run on ketones, or how myelin is made from fatty acid metabolism. I am going to, in endocrine, go through the hormonal regulation of glycolysis and gluconeogenesis. So this course is not going to be just random PowerPoint slides of metabolic pathways. I'm going to explain to you the big picture, as well as, most importantly, what is high yield for the USMLE. And that's my goal. My goal is to make sure that I narrow down the content for you such that I pick out what's high yield, and then secondarily, I show you how it is tested. So if you haven't already, please make sure you sign up for this integrative review. If you have any questions, please email me, rahul@highguru.com, and you can sign up with that Zoom link or at my website, highguru.com. So how did I create today's primer session? Well, I alluded to it earlier on in our introduction, but essentially what I did was I ended up going through the biochemistry section in first aid, as well as some high yield question banks. And I took the most commonly tested syndromes that are going to be seen on your exam, as well as on your NBMEs, and have roots in biochemical pathways. So we will take that syndrome, go through the underlying pathophysiology, and then go through the whole syndrome in an organ systems manner. So this is really important. Today, what we're going to be doing is we're going to be reviewing key biochemical and metabolic defects. We're going to have tons of multiple choice questions, and we're going to use that to spring into the biochemical pathways. This is going to be very important. Why? Well, remember that in your undergrad courses, in maybe your med school classes, they start with glycolysis, teach you all of glycolysis, and then they'll probably give you pyruvate kinase deficiency. Well, in order for me to be very high yield, I will tell you that the USMLE mostly always starts with the pathology and then asks you to derive the biochemical defect. This is not always true, but majority of the time, it is all rooted in taking the pathology and synthesizing it into the biochemistry. And that is going to be a great study tip for you as you move forward. So, like I said, biochemistry is going to be about 15 to 20% of your exam. And today's specific content spec is going to be integrating those multi-system processes and disorders questions. What we're going to do is we are going to really integrate each of these syndromes in a systems-based manner. I'm going to show you, hey, how does this syndrome affect the cardiovascular system? How does this syndrome affect the musculoskeletal system? And I'm going to compare and contrast some high-yield syndromes as well. So what is a syndrome? Well, a syndrome is a set of medical signs and symptoms which are correlated with each other and are often associated with one particular disease or disorder. And what I will tell you is that there is always going to be an underlying disorder, okay? There's going to be an underlying disorder. And that underlying pathophysiologic mechanism is going to form the basis for the symptomatology that you will see on your USMLE exam. Now, where is that going to be in your test question? It's going to be in the history of present illness, where they're giving you the signs and symptoms. It may be in the physical exam where they say, oh, this patient has clubbing, and that's going to kind of tell us that, oh, this must be related to some sort of syndrome related to hypoxemia. They may put this in labs as well. And so what we're going to do is identify the first fundamental pathophysiologic badness and then take it into an organ systems rotation. Okay. All right. So what I want to do is I want to lay down a fundamental USMLE test taking strategy. This is directly from my test taking strategies class. And that is, how do we recognize these syndrome or multi-system questions on the USMLE? And here is going to be the USMLE test taking strategy. And that is that whenever you see a multi-system involvement, i.e., there are many organ systems or symptoms that are at play that affect different organ systems, you always want to think about syndromes or systemic diseases. And I really want you to hone in on this test-taking strategy that you may see, oh my gosh, creatinine is up. Oh my gosh, the platelets are low. Oh my gosh, the patient has jaundice. Wait, this is affecting heme. This is affecting kidney. This is affecting maybe gallbladder, right? And so whenever you see many organ systems that are going to be involved in your test question, don't panic. Just say, hey, this is going to be some sort of syndrome or systemic disease, which means it affects many different organ systems. So let's break this test taking strategy down a little bit more. When I see multi-organ system involvement in the USMLE test questions, I always isolate what are the organ systems that are going to be involved. And then this is one of the few times that I look at the demographics that is in the first sentence. Specifically, I say, is this going to be an adult or a child? So say that there are many organ systems that are failing, and this is an adult. Well, then I know that this is a systemic condition. So what are some systemic conditions? Well, things related to hematology, like, for example, autoimmune hemolytic anemia. That is going to affect many different organ systems because blood flows through all different organ systems. Maybe this is going to be something like sepsis related to infectious disease that bacteria, the LPS from a gram negative is going to cause you to have such bad vasoplegia that no wonder you're going to have an elevated creatinine. No wonder you may go into DIC. Maybe another systemic example is something related to rheumatology, in which you have some sort of autoantibody to double-stranded DNA or anti-Smith. And now you have cytopenias, you're going to have oral ulcers, you're going to have serositis. And so these are just some examples of systemic diseases that they will test you on. So always think about hematology, infectious disease, and rheumatology when you see many organ systems that are going to be involved. Let's transition and talk a little bit about when the USMLE is going to give you multiple organ systems, but also they may give some characteristic facies. They may say, oh, the patient has prominent epicanthal fold, low set ears. Maybe they have some microcephaly, some hypotonia. Well, then you are going to isolate not only organ dysfunction, but also specific facies and say, oh, this is going to be some sort of syndrome or congenital issue, some embryologic or genetic basis for this current presentation. And so, like I said, today's approach is going to be just like what I do in the pediatric ICU. I break down problems based on respiratory, CV, neuro, FENGI, renal, heme, ID, MSK. We're going to be parsing out the various test questions by organ system with each of these high-yield syndromes. So without further ado, that is the introduction for today. If you are pumped to get started, go ahead and type in yes into the chat box. Can I get a yes into the chat box? All right, Andrea's ready. Sonia, Maria, great seeing you all today. I have one disclaimer, and that is right now we have about 120 people that are joining us. What I want to say here right now is that I only ask for 1 hour of your time. 1 hour of your time is all I ask for. And so please make sure you're focused. Make sure you're actively engaged in the chat box, because when you type it out, you remember it. Make sure you cut out all distractions and just focus with me, because I promise this is going to be so valuable for your preparation. All right, let's go ahead and get started with our first question. A newborn baby is found to have flat nasal bridge and single palmar crease. A murmur is heard at the sternal border. What is the likely genetic inheritance pattern behind this patient's presentation? Here's a warm-up question. I want you all to go ahead and put it in the chat. A, trinucleotide repeat. B, partial deletion. C, meiotic non-disjunction. Or D, uniparental disomy. And look at the chat box blown up. Everybody is saying C, and you're absolutely correct if you're thinking about Down syndrome or trisomy 21. So let's go ahead and first go through the key physical exam features and facies that you will see in your physical exam on the USMLE. Here we go. So patients with Down syndrome are going to have this flat nasal bridge. They're going to have prominent epicanthal folds. That's going to be right near the nose and near the eye flaps. They're going to have low set ears. They're also going to have abnormalities in the eye, specifically the colored portion of the eye, and we call those brush field spots. Patients with trisomy 21 are going to have a single palmar crease, and on their toes, their first and second digits may actually be be very widely spaced. So let's go ahead and integrate this. We see the flat nasal fold. We are going to see the prominent epicanthal folds right here. And we are going to see those low set ears related to trisomy 21. This picture right here is going to be representative of the single palmar crease. This is going to be that gap that you see in between the toes, known as a sandal gap toes. And then these are going to be the speckled portions of the colored portion of the eye. And that is going to be known as the brush field spots. So let's go through some high yield vignettes for Down syndrome. Question-based manner. Here we go. A child with trisomy 21 with echo showing atrioventricular valve regurgitation. So atrial and ventricular. What do you think is the diagnosis here? Well, this is going to be representative of the endocardial cushion defects that is related to Down syndrome. So let's just tie in and integrate some USMLE cardiac embryology. Remember that the endocardial cushion, which is right here, and I'm going to point the arrow right there, is going to form the basis for your valves, okay? And so when you are going to have abnormal endocardial cushions, you are going to have abnormalities in the valve such that you don't have great valves and you have atrioventricular valve regurgitation, i.e., now you have a common chamber known as an AV canal defect that is going to be mixing blue and red blood together and downstream going to present as low pulse ox on your vital signs in your USMLE question. And so that is very important for us to know, is that one of the cardiac defects related to Down syndrome is going to be the endocardial cushion defects. Let's go ahead and keep going. A newborn child with trisomy 21 who has not passed stool since birth has abdominal distension. What are we worried about here? So we have a newborn, they haven't passed stool, which that means that they haven't passed what is the first stool known as meconium. And so in this scenario, you are going to be worried about Hirschsprung's disease. Now, Hirschsprung's disease is going to be due to what mechanism? And that is a failure of migration of the Auerbach's myenteric plexus. And the USMLE loves to test this mechanism. Why? Because there's a histological integration, which we're going to get to. Now, let's transition this vignette and we say, same newborn baby, but actually rather than Down syndrome, they have cystic fibrosis. And now they can't pass this first stool. What are you worried about here now? Well, cystic fibrosis and failure to pass meconium, you're going to associate something known as meconium ileus. And we're going to talk about that when we talk about cystic fibrosis later on in this webinar. However, I want you to recognize that failure to pass meconium has three major differentials. A, you're going to have an anatomic defect, something like anal atresia. B, you're going to have a lack of the Auerbach's myenteric plexus. And so that is going to be related to Hirschsprung's disease. Or C, you're going to have a thick mucus plug at your terminal ileum cecal junction. And that's going to be characteristic of meconium ileus. So let's just do a quick histology integration. And that is understanding where is the myenteric plexus. And the Auerbach myenteric plexus is right here. It is going to be in between the inner circular and outer longitudinal muscle. And what we notice when we have a patient who has no inner circular, outer longitudinal muscle is that these patients are not going to have good peristalsis of poop throughout the GI tract. What happens is that you end up having a dilation of the colon because there is backup. And at this transition point, you recognize that there is no myenteric plexus. And thus, the patient is going to have backup of the poop, and they're not going to be able to have meconium going forward. And so that's why the diagnostic test is a rectal suction biopsy, because we take a suction piece of the colon and we look at it under the microscope and we say, hey, is there a plexus? Is there a ganglion in between the inner circular and outer longitudinal muscle? Because remember, embryologically, and the USMLE loves for you to know this, is that typically you have a myenteric plexus migration from proximal to distal. And so the failure of the migration of those neural crest cells is going to be the pathophysiologic basis of Hirschsprung's disease. So let's continue and talk about Down syndrome. Here, I'm going to give you an X-ray, and this X-ray shows that there is 2 air-filled cavities. Now, as a flip the classroom moment, go ahead and put in the chat. Do you think that this patient with Down syndrome and this X-ray, are they going to have bilious or non-bilious emesis? Go ahead and put that in the chat. Do you think they're going to have bilious or non-bilious emesis when you see this specific abdominal film? Awesome. And if you're saying that this is duodenal atresia, you're absolutely correct. Now, what is the likely mechanism when it comes to duodenal atresia? Well, it is the failure of the endodermal gut tube to recanalize. Remember that you start with this cylindrical tube, and canalization is basically making a hole, making it into a hollow cylinder. And if that process is going to be messed up, you can have what we call duodenal atresia, or the duodenum doesn't develop. So now let's go ahead and talk about this specific pathology. A patient with trisomy 21 has bilious emesis. Maybe they have the same KUB or abdominal film. And now you note that there is external gut tube compression. So similar presentation to duodenal atresia with the bilious emesis, but now you're saying that there is external gut tube compression. And so if you are thinking annular pancreas, you're absolutely correct. Remember, in annular pancreas, what ends up happening is that the ventral and dorsal bud of the pancreas do not migrate and fuse properly. In fact, what they do is they form an annulus, which means ring, surrounding the duodenum, and you end up having the similar presentation as duodenal atresia. And so remember that annular pancreas associated with Down syndrome as well, it is an external compression of the duodenum because there is a failure of the dorsal and ventral bud of the pancreas to fuse. Now, let's go ahead and break down Down syndrome in a systems-based manner. Ladies and gentlemen, if you are learning a lot right now, go ahead and type in yes into the chat box just so that I know you're paying attention. Excellent. Wow. Look how many people are active and engaged. Thank you so much. I really appreciate your attention. Cardiology, we talked about the atrioventricular septal defects, or what we call the endocardial cushion defects. You also are going to have membranous VSDs. You're going to have an ostium primum ASD. Very important. Okay. From a GI standpoint, you're going to be thinking about duodenal atresia, remember double bubble, and the bilious emesis, annular pancreas, as well as Hirschsprung's disease. Now, from an endocrine standpoint, think about patients with trisomy 21 as very autoimmune. What does that mean? Well, they may have a predilection to becoming hypothyroid. They may have a predilection to develop type 1 diabetes. And how does type 1 diabetes present on the USMLE? As DKA usually. From a neurological standpoint, what do patients with Down syndrome have a predilection to? Well, they have a propensity to having early onset Alzheimer's, specifically around the age of 40. And why is that? Well, what ends up happening is that if you go back to normal neural processes, you have something known as the amyloid precursor protein. And that amyloid precursor protein is on chromosome 21. Now, I'm going to describe to you normal right now. And what you notice is that the amyloid precursor protein can undergo alpha secretase or cleavage or beta cleavage. All right. And so what happens is that when you have excess amounts of beta cleavage with the amyloid precursor protein, you can end up having in the brain A beta plaques that form. And remember that A beta plaques are the hallmark pathology, microscopic pathology for Alzheimer's disease. And so patients who are going to have 3 copies of chromosome 21 are going to have 3 copies of APP and are going to have more likelihood to undergo beta cleavage and subsequently develop A beta plaques. All right, very good. So let's go ahead and go through the respiratory tie-ins. From a respiratory standpoint, patients with trisomy 21 are going to be very hypotonic. And as a future pediatric critical care physician, this is something that I really need to worry about when I'm managing the airway of a child with Down syndrome. Another thing that I have to worry about is their large tongue, such that if I have to secure their airway, I need to make sure that I take into account their excess pharyngeal tissue as well as the airway hypotonia. Now, over time, these patients who have such bad airway hypotonia are going to have obstructive sleep apnea. And remember that when you have obstruction in your lungs, the vasculature is going to suffer. And why is that? Well, if you have obstruction, i.e. this alveoli clamps down, your P big A CO2 is going to go up. And as a result, you end up developing hypoxemia because you're unable to take that bad gas out. Well, what happens is that then the capillary, right at the alveolar capillary interface, is going to vasoconstrict because there's a physiologic process in the lung known as hypoxic vasoconstriction. And that hypoxic vasoconstriction over time is going to create pulmonary hypertension and increase right ventricular afterload, because remember, right ventricle is going to pump blood into the lungs, and subsequently you're going to get RV failure known as cor pulmonale. How are patients going to present? They're going to present, if they're older, as JVD. They're going to present with hepatomegaly, maybe some peripheral edema. And remember, they're going to have clear lung sounds. And that kind of differentiates left heart failure from right heart failure. And remember, how does heart failure present in kids? Well, heart failure in kids is going to present as not growing well. They're going to have tachypnea with feeding. They're going to be sweating a lot. Why? Because their heart is causing a hypermetabolic state. All right, Down syndrome continued from a hem-onc standpoint. The questions you have to watch out for are early onset leukemia. Either you're talking about the M3 AML, which is, acute megakaryoblast leukemia or AML, or you're going to be thinking about ALL. And remember that leukemia typically on your USMLE presents as pancytopenia because the leukemia takes over the bone marrow, or it presents as a very, very high white count. And what you have to do is you have to differentiate whether this high white count is going to be due to infection, what we call a leukemoid reaction, or whether or not this is going to be due to some sort of leukemia. Finally, from an MSK standpoint, you want to recognize not only the muscle hypotonia, but the atlantoaxial instability. And remember that the atlas and axis are going to be your upper cervical vertebrae. And what happens is that this atlantoaxial ligament is going to be very, very loose, such that when you are going to have hyperextension of the neck, if you have very bad atlantoaxial instability, you could sever the upper cervical spinal cords, and that could be very life-threatening. And so this is important for us to recognize, not only in Down syndrome patients, but in patients who are going to have weakness of that atlantoaxial ligament. And those are going to be patients who have, for example, rheumatoid arthritis. They are going to have such inflammation of their connective tissues that they could also present with atlantoaxial instability. All right. Real quick, let's go through the other three trisomies. I'm going to kind of weave you through this path. Let's talk about Patau syndrome. Remember, Patau syndrome is trisomy. Go ahead and put that in the chat. Trisomy what? What number? Excellent. If you're saying 13, you're absolutely correct. I remember that puberty is at 13. So Patau syndrome, P and puberty. Now, with Patau syndrome, what are the faces you're going to get? You're going to get microcephaly, cleft palate, microphthalmia, which is basically going to be small eyes. In Patau syndrome, the MSK defects are going to be these rocker bottom feet. As you can see, this looks like the bottom of a rocking chair. From a GI standpoint, you're going to have this outpouching of the peritoneum that is covered by the peritoneal membrane, and that's known as omphalocele. And from a cardiac standpoint, you're going to have VSD and PDA. So what I like to do when it comes to a lot of these syndromes, just as a study tip, is I like to really hone in on the key defining feature, what I call the sentinel feature, the defining feature of that genetic syndrome. And for me, Patau syndrome, the defining feature in all vignettes is that there's midline defects. And that's important because, as you can see, midline defects, cleft palate, midline defects, omphalocele, midline defects, VSD. And so you should try to categorize and learn a lot of these syndromes by first honing in on what is that high yield defining feature. Edwards syndrome, Anoop put in the chat. Thank you so much. Election is going to be the mnemonic that I also use. You elect people in the United States at 18 years old. So Edwards syndrome, you're going to have trisomy 18. The facies for Edwards syndrome, micrognathia, low set ears. You may also have what we call a prominent occiput. From an MSK standpoint, these patients are also going to have rocker bottom feet, just like Patau syndrome. However, they're going to have this unique clenched fists with overlapping fingers. And as you can see right here, the clenched fists with the overlapping fingers, that's really important for you to recognize with Edwards syndrome. What are the cardiac manifestations? Well, you're going to have VSD, ASD. There are even some case reports that are associated with tetralogy of Fallot. And unfortunately, patients with Edwards syndrome have a poor lifespan prognosis. All right, let's go ahead and transition to this question. A researcher is studying DNA disorders. It is found that a novel enzyme, which mimics S-adenosyl methionine, or SAM, modulates DNA transcription and downstream translation. This enzyme plays a crucial role in which of the following processes? A, meiosis. B, heterozygous recombination. C, imprinting. D, mitochondrial inheritance. What do you all think? That here you're having this enzyme SAM, which I'll give you a hint is a methyltransferase enzyme. What is that going to be implicated in? Awesome. And if you said C, you're absolutely correct. The answer is going to be imprinting. Remember that methylation is going to mute DNA. And so imprinting disorders is what we're going to be talking about next. When we talk about disorders of imprinting, we are going to be thinking about two major disorders for the USMLE. And that is going to be Prader-Willi syndrome and the second one being Angelman syndrome. So Prader-Willi and Angelman syndrome. Remember, in Prader-Willi syndrome, the paternal gene is going to be the one that is going to be deleted. In Angelman syndrome, you are going to have the maternal gene that is going to be deleted. And that deletion can be remembered by this mnemonic, that P Prader-Willi, P paternal gene deleted. Angelman syndrome, the maternal gene is going to be deleted. Now, what's important for us to recognize is that, fine, in Prader-Willi syndrome, the paternal gene is deleted. However, what is methylated, what is silenced, is the maternal gene. And that is the one that is imprinted. Subsequently, for Angelman, the maternal gene is deleted, but the paternal gene is silenced due to methylation. And so here you see that we have a silenced, because there's a lot of methyl groups, a silenced paternal gene. And let's say that this maternal gene was going to be deleted. What do you think is going to be the diagnosis here? Go ahead and put that in the chat. Is it going to be AM, Angelman's, or PW, Prader-Willi? Go ahead and put that into the chat. Wonderful. You're absolutely correct if you put Angelman syndrome, because in Angelman syndrome, the paternal gene is going to be the one that is going to be imprinted, and the maternal gene is going to be deleted. All right, so let's talk about Prader-Willi syndrome. In Prader-Willi syndrome, the characteristic facies are thin almond-shaped eyes, as well as the thin upper lip. What's important for us to recognize that a thin upper lip is also going to be the differential for fetal alcohol syndrome. Remember, they have smooth philtrum as well as thin upper lip. In Prader-Willi syndrome, however, these patients are going to be very obese. And I think that this is important for us to recognize, but let's integrate that a little bit more. Remember that in your vital signs, specifically when they give you the growth parameters, they will put a BMI of greater than 30. And so you need to take that quantitative numerical data and turn it into qualitative data, which is going to just mean that, hey, I need to recognize that a BMI greater than 30 is going to refer to obesity. Now, these patients are also going to have short stature, and that's usually because of some sort of hypothalamic disorder, such as growth hormone deficiency, and they're going to be very hypotonic. But as you can see, the defining feature or the sentinel feature of this syndrome is going to be obesity. Let's transition and talk a little bit about the counterpart, which is going to be Angelman syndrome. In Angelman syndrome, the characteristic facies is going to be microcephaly, intellectual disability, and laughing. This inappropriate laughter is going to be something that you see time and time again in questions related to Angelman syndrome. Now, from a neurological standpoint, what's also a key defining feature is epilepsy or recurrent seizures. And so these patients are going to have inappropriate laughter, recurrent seizures, and they can even have these upper motor neuron signs that are going to be characterized as hyperreflexia with truncal hypotonia. All right, let's go ahead and transition and talk about this question. A 35-year-old male is admitted due to chest pain. He is found to have a myocardial infarction. LDL levels are within normal limits. Increases in homocysteine are noted. A B6 deficiency is also noted. Which of the following conversions may be affected? Go ahead and put your answer into the chat. All right, this is going to be a unique question because this question is going to test you on homocystinuria, the fact that homocystinuria can cause premature cardiogenic thrombi, and the fact that homocystinuria related to a B6 deficiency is going to create a deficiency in taking homocysteine to cysteine. So now let's go ahead and jump into the biochemistry pathway. Remember that we are going to take amino acids that we take from the diet, such as methionine, an essential amino acid. And what we do is we take that amino acid and we kind of shunt them to different amino acids. One of the key amino acid transitions that you have to know is going to center around homocysteine. Now, homocysteine needs to be converted into either methionine or cysteine. And why is that? Because when you have high homocysteine levels, just like Virchow's triad getting integrated here, you're going to be hypercoagulable. And so that's why in the test question, you saw the patient having premature atherosclerosis. So the classic homocystinuria, the genetic one, is going to be related to a CBS enzyme deficiency. And cystathione beta synthase is going to be an enzyme that requires vitamin B6, such that if you have elevated homocysteine levels, low B6, and thus low CBS activity, you will not be able to take homocysteine and turn it into cysteine. Now, there's another pathway that is going to be related to what we call the folate trap. And the folate trap is also important for us to recognize. And this is one of the acquired forms of homocystinuria. What we see here is that homocysteine needs to actually be made into methionine, okay? Homocysteine needs to be made into methionine. So how does that work? Well, remember that we get folate from green leafy vegetables. And what we need to do in our body is we need to methylate that folate. As soon as we eat that kale, we're going to methylate it. And once we methylate it, our body can start using it. Once we end up having that methyl group on folate, a series of reactions takes that same methyl group and puts it onto B12. So we're basically hot potato. We are going to be passing on the methyl group. Subsequently, this B12 is going to take this methyl group and it's going to say, I don't want it. I am actually going to put the methyl group on homocysteine. And whenever you methylate a homocysteine, it becomes a methionine. And so what's important for us to recognize is that if you have, for example, a B12 deficiency, you are unable to transfer now this methyl group from folate. You can't transfer it onto B12 because there's no B12 there. And subsequently, you can get elevations in your homocysteine levels. And that's one of the key concepts behind the folate trap and homocystinuria. So patients who are going to have homocystinuria are going to have what we call a marfanoid habitus. And I really want to kind of integrate how that looks on your physical exam sentence in your USMLE vignette. And that is that patients with marfanoid habitus are going to have this tall, thin build. They're going to have flexible joints as well as scoliosis. From a facies standpoint, these patients are going to have issues with lens dislocation, which we'll talk about. They're going to have a high arched neck and crowded teeth. They're also going to have a very characteristic and sentinel physical exam feature known as a pectus deformity, either carinatum or excavatum, so chest wall deformities. Now, the other thing that these patients are going to have are these long arms with very, very long fingers. And so this is going to be a very classic habitus for you to recognize on the USMLE because there are going to be some various differentials for you to know. Now, patients with Marfan syndrome are going to have, or especially with marfanoid habitus, they're going to have issues with their blood vessels, specifically related to their aorta. They can have aortic dilation, aneurysms, or even dissections. They're also going to have, at times, redundant connective tissue right on the mitral valve, and that's going to be known as mitral valve prolapse. Patients with a marfanoid habitus are going to also have a predilection to develop what we call apical blebs, basically outpouches of air that can suddenly pop and give you a spontaneous pneumothorax. So if you see on your exam question a patient who has Marfan syndrome and they suddenly have shortness of breath, you are going to be thinking about, rupture of apical blebs that are going to create a spontaneous pneumothorax. So what's important for us to recognize is that the USMLE is going to give us many different chest x-rays. And one of the chest x-rays that they want you to recognize is this widened mediastinum. And the widened mediastinum actually refers to the aortic dissection. And so say that they give a patient who is going to have this tearing chest pain, a marfanoid habitus, and they are going to give this x-ray of a widened mediastinum, you're going to be worried about an aortic dissection. This picture is what I was just talking about related to the spontaneous pneumothorax. And as you can see here in this picture, you have the lung, which is here, that has collapsed down, and a lot of blackness, which is going to just be air. And remember that the mechanism behind the spontaneous pneumothorax, which is air in the pleural space, the mechanism is going to be a rupture of that apical bleb. All right, let's go ahead and talk about this next question. Which of the following maneuvers will increase the intensity of this murmur description? When I say mid-systolic click, what murmur do you think of? And which of the following maneuvers is going to increase the noise of that murmur? Go ahead and just put in the multiple choice answer into the chat box. All right. And real quick, is there still some microphone feedback? Can somebody just confirm that for me? All right. Let me see if I'm going to just change my microphone. Does that help? All right. Wonderful. So when it comes to your murmur description that is going to increase your mitral valve prolapse, the correct answer is going to be D, Valsalva. Remember that in mitral valve prolapse, what you have is you have this redundant connective tissue right on the mitral valve. And whenever you have this redundant connective tissue, whenever the heart is going to be very, very empty, the connective tissue is going to parachute up, and that redundant tissue is going to click, 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 click right on top of each other. And so the key concept here is that an empty heart, i.e., a heart devoid of preload, is going to cause you to have an earlier onset of the mid-systolic click. And that is going to be very important. Why? Because that then is going to suggest that the murmur is going to be louder. Now, what is another cardiac lesion that gets louder with decreased left ventricular end diastolic volume? I'll give you a hint. Left ventricular end diastolic volume, also known as preload, but I wanted to integrate that concept in. And if you said hypertrophic obstructive cardiomyopathy, you are absolutely correct. Just so that I can draw that in a clear manner, here is going to be your heart, forgive my drawing. Here is going to be the LV. And remember, we're talking about hypertrophic obstructive cardiomyopathy, which is going to be a defect and a hypertrophy of the interventricular septum. Now, whenever you have maneuvers that are going to be decreasing preload, for example, you're going to have Valsalva, or you're going to have standing, for example. Any maneuver that decreases your left ventricular end diastolic volume, again, that's going to be a synonym for preload, you are going to now have an empty heart, and that empty heart is going to allow the interventricular septum, which is going to be hypertrophied, to hit the ventricular free wall. And I think that that's a very important concept for us to recognize, is that an empty heart is going to cause the murmur for hypertrophic obstructive cardiomyopathy to be louder. Now, remember that hypertrophic obstructive cardiomyopathy, usually on your USMLE, presents as an athlete who is going to have syncope or sudden cardiac death. And they may have this lesion as their underlying cause. All right, so we talked about Marfanoid habitus, we integrated mitral valve prolapse. Now let's go ahead and talk about the differential diagnosis of Marfanoid habitus for the USMLE. When you're thinking about Marfanoid habitus, think about good old Marfan syndrome, which is going to be a fibrillin 1 mutation, and that gives you what? Poor elastin. Second, you want to think about homocystinuria. Homocystinuria also is going to be related to the CBS deficiency, Marfanoid habitus, and a hypercoagulable state. Number three, you want to understand that patients with Klinefelter syndrome are going to have Marfanoid habitus. And remember, this is going to be an example of hypergonadotropic hypogonadism. And then finally, you want to integrate MEN2B, which is multiple endocrine neoplasia 2B, which is associated with the RET oncogene mutation, Marfanoid habitus, oral gangliomas, and bilateral pheochromocytomas. This is a very important slide. Take some time to just scan it. Excellent. And now let's go ahead and keep going. So Marfan syndrome, I'm going to be talking about the one that is specifically related to the fibrillin 1 defect. The fibrillin 1 defect is then going to cause what? Bad elastin downstream. And elastin is going to be what makes your skin nice and rubber bandy. Now, in this connective tissue disorder, you are going to have issues with the lens being dislocated. This is a subtle point that the USMLE likes to go for. And that is that with Marfan syndrome, the lens go up superior and lateral temporally, superior temporally. Whereas in homocystinuria, you are going to have the lens go inferomedially. towards the nose. Patients with Marfan syndrome are going to have hyperextensive skin, just like Ehler's Danlos syndrome, joint hypermobility, and they could even have winged scapula, which, remember, we associate winged scapula with what nerve damage? That is going to be the long thoracic nerve. From a neuro standpoint, these patients are going to have connective tissue defects in the blood vessels of the brain, and that can lead to berry aneurysm formation and, bam, a thunderclap headache on your USMLE, which is going to be subarachnoid hemorrhage. You also want to integrate aortic root abnormalities and mitral valve prolapse, which we went through, and from a respiratory standpoint, the spontaneous pneumothoraces. A patient is found to have increased flexibility. The patient is noted to have a family history of circus contortionists. Which of the following defects is most likely present in this patient? So a very hyperflexible patient and a family history of that. You're going to be thinking of. This is a unique question. And specifically, this is going to be related to D, collagen defects. This joint hyperflexibility that is going to be pervasive throughout families, that is not really associated with any other organ systems, is going to be very characteristic of Ehlers-Danlos syndrome. So Ehlers-Danlos syndrome, in the classic type, which is encoding in the basement membrane, you have a type 5 collagen defect. In the vascular type, you have a type 3 procollagen defect. And usually issues with Ehlers-Danlos syndrome are rooted in normal collagen synthesis. Again, my goal is to go back to the normal, and that is recognizing that in one of the steps of collagen synthesis, you need to cleave the peptidases. Once the precursor collagen molecule is secreted into the extracellular matrix, you need to cleave those peptidases. And a failure to cleave those peptidases on the sides of the collagen molecule, the developing collagen molecule, is going to form the pathophysiologic basis behind Ehlers-Danlos syndrome. Now, these patients can have retinal detachment, they can have mitral valve prolapse, they can have hyperextensibility of the skin, easy bruising, poor wound healing, and from a GI standpoint, they are going to be prone to hernias. Again, connective tissue is going to be bad. Let's go ahead and go through this question here. A child presents with intellectual disability and aggressive behavior to caretakers. On exam, there are joint tophi and nails which are bit. Labs show elevated uric acid levels. Which of the following enzymes may be implicated in this disorder? A, TS, B, HGPRT, C, orotate, or D, CPS1? Awesome. And I want everybody to be answering this question, typing out the answer to the chat box. You're absolutely correct if you put Lesch, Nyhan, 8G-PRT. Very good. So let's just go ahead and integrate the purine salvage pathway. I want to give you the big picture, and that is that purine salvage is essential in creating nucleotides from degradation of DNA and RNA. And that's really, really important, that when DNA and RNA are going to be broken down, we kind of want to recycle some of those products so that we can make purines again. And so one of the enzymes that helps us recycle those broken down products is going to be HGPRT. And HGPRT is going to help us regenerate IMP and GMP, which are nucleotides. So what it's going to do is it's going to take the recycling bin of guanine and going to turn it back into GMP. It's going to take the recycling bin of hypoxanthine and it's going to turn that back into IMP. So what's important for us to recognize is that patients who have HGPRT deficiency are going to have an upregulation of PRPP, which is the de novo enzyme or the de novo sugar that we are going to need to make de novo purines. That's going to work over time. You're going to have less purine salvage. And now all this recycling bin material, hypoxanthine and guanine, guess what? They are going to be going and forming uric acid. And so that's why patients with Lesch-Nyhan syndrome, HEPRT deficiency, are going to have bad purine salvage, and subsequently, they're going to have elevations in uric acid and gout. Lesch-Nyhan syndrome, let's integrate it. From a neurological standpoint, these patients are going to have developmental delay and self-injurious behavior. In fact, the elevated amounts of uric acid are going to cause striatal dopaminergic damage. And that's one of the mechanisms implicated. The oxidative damage in the brain is going to be the basis of what causes the self-mutilation. And so that's why you can see like nail biting, for example. From an MSK standpoint, these patients are going to have gouty arthritis. And from a renal standpoint, they're going to have a tendency to form urate crystals. And remember that these are these diamond-shaped or rhomboid-shaped crystals, which are going to precipitate in acidic pH. And so a couple things to integrate with uric acid stones is the following. Ready? Number one, you have to recognize that they're going to be radiolucent on your radiographs. That's different than calcium stones. And number two, because they form in low pH situations, urine alkalinization may be one of the mainstays of treatment. And so welcome to High Guru. Integration is going to be what gets your score up. All right, ladies and gentlemen, let's pause right here. Let's take a deep breath together. Come on, let's do it together. No, seriously, let's do it together. All right, we have 20 more slides left. Are you excited to go ahead and learn? Go ahead and type in yes into the chat box. 20 more slides left. Awesome. Hasina, Anjum, Andrea, everybody is pumped. Let's go for it. A 5-year-old male presents with respiratory distress. He is noted to have recurrent sinus infections and otitis media. And I gave you a pertinent negative. IgA levels are normal. Genetic analysis reveals a microtubule abnormality and subsequent ATPase defect. Which of the following cellular structures is most likely implicated? A, IL-2, B, flagella, C, dynein arms, or D, chloride channels? Excellent. And if you're thinking about primary ciliary dyskinesia, you are correct. The answer is dynein arms. Remember that normal cilia have a 9+2 microtubule configuration. So let's go ahead and integrate primary ciliary dyskinesia, which we call Kartagner syndrome. Now, the primary disorder is going to be a dynein arm that is not going to be working. So let's go through normal first. Remember that your cilia are going to be arranged in a 9 doublet, which is you see on the outside of this picture, and 2 singlet microtubules. Now, if you kind of visualize with me here, in between these doublets, you have these arms known as ATPase, these arms that I'm drawing in. And these arms are what beat the cilia back and forth. And that arm is known as a dynein ATPase. So what ends up happening in primary ciliary dyskinesia is you have a defect in that dynein arm, that ATPase, such that the cilia are immotile and you thus have poor epithelia. What epithelia are going to need cilia? Well, epithelia related to the respiratory system, embryologic epithelia related to cardiac embryology and formation, and your reproductive tract, specifically your fallopian tubes, as well as your vas deferens and your sperm. What's important is that patients who have primary ciliary dyskinesia are going to have bronchiectasis, which is a persistent dilatation of the bronchi. In your questions, they're also going to have recurrent sinusitis. Patients who are going to have recurrent sinusitis and say they have hematuria remember a differential diagnosis to keep in mind is going to be granulomatosis with polyangiitis, formerly known as Wegener's. From a cardiac standpoint, these patients are going to have displaced heart sounds, and that is going to be related to the fact that they could have abnormal cardiac folding, and their left ventricle could be on the right side of the patient. That's known as situs inversus. And then finally, from a reproductive standpoint, these patients can have infertility because your fallopian tube cilia ain't working, as well as your sperm and your vas deferens. All right, here's another USMLE vignette, kind of related to Kartagner syndrome. A newborn child with failure to thrive and abnormal IRT. What is the likely chromosomal abnormality? Go ahead and type in the number that you think is implicated in this disorder. What number is going to be implicated? I see a 7. If you're thinking IRT related to cystic fibrosis, you're absolutely correct. It's going to be chromosome 7. This is what we actually test in the newborn screen. On the newborn screen, we test the immunoreactive trypsinogen. If you have an elevated IRT, that suggests that you may have cystic fibrosis and you may need a confirmatory test. Remember that in cystic fibrosis, it is going to be a mutated CFTR gene that causes a misfolding of a ATP-gated chloride channel. Remember, channels are proteins. So a gene defect is going to lead to a misfolded protein most commonly. What gene defect is important for us to recognize? Remember the delta F508, which is going to encode for, at the 508th position, a deletion in phenylalanine. So what is the difference in sweat glands, CFTR, and other exocrine glands? Let's go through the normal. The normal is that sweat glands normally, as you have more sweat, they reabsorb chloride. And exocrine glands, as they secrete, for example, lung juice, i.e. mucus, the lung CFTR ends up opening the chloride channel, and rather than reabsorption, there's secretion in exocrine glands. And that's why the CFTR gene in the lungs, for example, is encoded to help thin secretions downstream by releasing the chloride into the ductal lumen. In cystic fibrosis, you can't, in the sweat glands, reabsorb. And that's why you have salty skin and you have an abnormal sweat chloride test. And in the GI tract, in the pancreas, in the lungs, in the exocrine glands, you have a failure to secrete that chloride, and thus you have very thick secretions. Okay. Excellent. So USMLE vignettes for cystic fibrosis. A teenager with cystic fibrosis who now has elevated blood sugars and elevated hemoglobin A1C. What is the likely mechanism? Well, remember that patients with cystic fibrosis can have the tendency to have an exocrine gland defect. They're going to have thick pancreatic secretions, and subsequently that can cause you to have an endocrine pancreas insufficiency, such that you can develop secondary diabetes. Because remember, the beta islet cells, insulin is going to be within the actual pancreas. Now, how would an exocrine, not an endocrine, but an exocrine pancreatic insufficiency present on the USMLE? Well, steatorrhea, because you're not reabsorbing your fats. You're going to have malabsorption, foul-smelling stools, hypoproteinemia, as well as a deficiency of fat-soluble vitamins. Let's integrate some GI real quick. Ready? A cystic fibrosis patient has an abnormal DEXA scan or a bone scan. What is the likely mechanism here? And that is going to be abnormal vitamin D metabolism and reabsorption that leads to osteopenia or osteomalacia. And so here what we did was we started with cystic fibrosis, went through the cellular, went through the endocrine pancreas, exocrine pancreas, tied in some GI nutritional deficiencies. This is how you're going to learn. And remember, all of my other reviews on my YouTube channel, on my courses, are in this integrative fashion. So what we want to do is we also want to tie in some microbiology related to cystic fibrosis. As you can see on the left-hand column, there are going to be many different bacteria. And with these bacteria, you need to recognize that patients with cystic fibrosis can be colonized or be infected with these bacteria. Why? Because they got thick secretions in cystic fibrosis, and bacteria just love to chill on thick secretions. Thick secretions are like a glue for Staph aureus to stick. And so remember that Staph aureus on your USMLE, they'll say gram-positive cocci in clusters that are going to be catalase and coagulase positive. And these patients with cystic fibrosis typically are going to have Staph aureus infections early on, whereas Pseudomonal infections are going to be in the adulthood. Pseudomonas aeruginosa is going to be a gram-negative bacilli that is going to be oxidase positive. Remember that you want to use aminoglycosides, especially inhaled formulations of aminoglycosides, to decrease the Pseudomonal colonization and CF exacerbations you can have due to Pseudomonas. So what are your aminoglycosides? Ready? 1, 2, 3, gentamicin, neomycin, amikacin, tobramycin. And remember that aminoglycosides are going to be 30S ribosomal subunit inhibitors. Aspergillus is going to present in CF patients as asthma-like symptoms, recurrent pneumonia. Remember that they can have eosinophilia because it's a fungal mold species that has acute 45-degree branching. And then finally, if a cystic fibrosis patient is going to have a very pervasive necrotizing pneumonia and sepsis, you're going to be thinking about Burkholderia cepacia, which is also a gram-negative bacteria. And so this chart just shows us right here that Staph aureus is going to peak in the young. And as you can see, it's like around 6 to 10, whereas something like Pseudomonas aeruginosa is going to peak a little bit later on. Let's go ahead and integrate cystic fibrosis. From a respiratory standpoint, these patients are going to have nasal polyps, and nasal polyps are going to be bilateral in cystic fibrosis. And remember that in aspirin intolerant asthma, they're also going to have nasal polyps. So differential is going to be aspirin intolerant asthma. Pneumonia can cause a breakdown of your basement membrane epithelium, and thus you can get bronchiectasis. And bronchiectasis can lead to obstructive lung disease. You can also get hemoptysis as well, because now all of that tissue in your lung is friable, such that when you have a forceful cough, you're going to, bam, pop open blood vessels. From an MSK standpoint, you're going to have digital clubbing. From a genitourinary standpoint, these patients are going to have thick secretions in their GU system. So think about obstructive azoospermia. They may even have an anatomic defect, which is going to be vas deferens going to be absent. And from a GI standpoint, they can have meconium ileus, which we talked about, as well as in adults, because of the thick secretions, they can have distal intestinal obstruction, such that here is the colon, and you notice that right here where the star is, there's a mucus plug, and that's why the small intestine is not lighting up. And so that's known as a distal intestinal obstruction. And this presents as acute abdominal pain in a patient with cystic fibrosis, and they are going to have bloating as well as colonic dilatation. Moving on here, a patient is noted to have a Bode fracture. It is noted that she had puberty at a very young age. Exam shows hyperpigmented patches of skin with irregular borders on her chest and trunk. What is the likely diagnosis? A, NF1, B, NF2, TS, McCune Albright, or Albright hereditary osteodystrophy. And with the triad of precocious puberty, the cafe au lait spots, as well as the bone tumors, you're thinking about McCune Albright syndrome. Remember, Albright hereditary osteodystrophy, that's the one with the digits and the parathyroid hormone mutation. So McCune Albright syndrome, we got to understand that the underlying pathology is a GS activating mutation. You get excess cyclic AMP. That causes you to have this bone issue, what we used to call brown tumors of the bone, but you have this fibrous dysplasia, this ground glass appearance of the bone that is then going to be very prone to fracture. From an endocrine standpoint, a defining feature of McCune Albright syndrome is precocious puberty as well as Cushing syndrome. And from a skin standpoint, you have this really big cafe au lait spot, what they call the coast of Maine cafe au lait spot. Speaking of cafe au lait spots, let's go ahead and integrate neurofibromatosis. In neurofibromatosis, you're going to have a correlate to the brain being seizures and meningiomas. Remember that the eyes in neurofibromatosis, you're going to have these Lesch nodules, which are speckled portions of the iris. From an ear standpoint, especially with NF2, you're going to be thinking about acoustic neuromas. Watch for tinnitus, hearing loss, and vertigo in your test questions. And then finally, these cafe au lait spots, that's what got us into this integration. Remember that when you see cafe au lait spots, don't always knee-jerk to neurofibromatosis. If they have precocious puberty and bone stuff, you're going to be thinking about Cune-Albright syndrome. Now, I always like to compare and contrast neurofibromatosis with tuberous sclerosis. In tuberous sclerosis, these patients have seizures, specifically infantile spasms. They're going to be spasming a lot. And they can have cardiac abnormalities known as cardiac rhabdomyomas. Make sure you check out my high-yield neurology review to go through the cardiac rhabdomyomas. Also, these patients are going to have kidney tumors known as renal angiomyolipomas. They're going to be filled with blood vessels, muscle, which is here, and then fat cells, angiomyolipomas. And then finally, the skin abnormalities are going to be these hypopigmented spots. That's different than cafe au lait spots. Hypopigmented spots, those are known as your ash leaf spots. Last question of the day. A patient presents with fever, fatigue, and weight loss over the past 3 weeks or months, excuse me. It is noted that she has anemia with increase in ferritin. UA shows proteinuria and red blood cell casts. What is the likely diagnosis here? A, SLE or lupus. B, ankylosing spondylitis. C, dermatomyositis. Or D, polymyalgia rheumatica. Excellent. If you're saying A, you're absolutely correct. This is going to be lupus. I really want you to integrate this test-taking principle. And that is recognizing constitutional symptoms related to lupus. These patients are going to have an autoimmune attack or a type 3 hypersensitivity antigen antibody complexes that are going to be depositing that causes what? Multi-system involvement. So let's go through this. What are the HLA subtypes present which explain the genetic predisposition? That is going to be small detail, but important, HLA-DR2 and HLA-DR3. What are the environmental factors which contribute to the pathophysiology of lupus? So there's genetic and then there's environmental. So things like UV light, things like drugs, which specifically procainamide, which is an antiarrhythmic, hydralazine, an antihypertensive. So say that they give you, hey, I give you that drug and now you have a lupus-like syndrome, what we call drug-induced lupus. So they give the drug and in the test question, they say joint pain or a rash. You're going to get what serum blood test? That's an antihistone antibody, which is associated with drug-induced lupus. What is the underlying pathophysiology of lupus? Well, there's type 3 and type 2. So let's go through this. Type 3 hypersensitivity, remember, that is going to be related to antigen antibody complexes that are going to deposit in tissues such as the skin, the kidneys, the joints, and the blood vessels, and cause activation of complement. Once you activate complement, that tissue becomes angry. Remember, the kidneys are going to have this really important pathophysiologic mechanism. And that's why you have a positive immunofluorescence, because you are going to have antigen antibody complexes that are going to be depositing in the kidney. Now, the type 2 hypersensitivity pathophysiologic model is going to be why in test questions for lupus especially, you are going to have a decreased WBCs, decreased hemoglobin and hematocrit, and decreased platelets because it's autoantibodies to different types of cells. So just as a immunological tie-in and test-taking principle, remember, fever, fatigue, and weight loss usually means that there's a chronic inflammation process going on. IL-1, IL-6, TNF-alpha are going to be elevated. So think about lupus, think about rheumatoid arthritis, think about some cancers as well. So when we think about lupus, let's go through the skin changes. And that is recognizing that these patients have that malar rash that spares the nasolabial folds. Patients with lupus can also have a specific type of lupus known as discoid lupus. And in discoid lupus, you have like craters in your skin, alopecia, and hypopigmentation. Patients with lupus may have oral ulcers. And so oral ulcers like aphthous ulcers are going to be seen in lupus, but you also want to differential diagnosis that with, Crohn's disease. Ooh, that's a good one. And then finally, remember that patients with lupus are going to have Raynaud's as a vasospasm type of skin change. Let's go through the vascular abnormalities. Remember, type 3 deposition. In the vascular abnormalities, you're going to have really important tie-in, and that is antiphospholipid syndrome. This is really important here. In antiphospholipid syndrome, you end up getting autoantibodies and cellular deposits to your phospholipid membrane. That causes what? That causes endothelial cell injury. And that endothelial cell injury is actually really important for us to recognize. Why is that? Well, because the endothelial cell injury integrates with GenPath, Virchow's triad, you become very, very hypercoagulable. And you can see not only thromboembolic phenomena, such as PE, DVTs, but you can get placental abnormalities. And that's why patients with lupus can present as recurrent abortions. So what's high yield for us to recognize here is that patients with antiphospholipid syndrome can have actually abnormalities in their PTT. Their PTT may be elevated, which may make you think, there might be more bleeding. Actually, in antiphospholipid syndrome, this is paradoxical. The high PTT actually is going to correlate to a more hypercoagulable state when you're talking about antiphospholipid syndrome. From a hematologic standpoint, remember that you get a pancytopenia. And if you have things like low platelets, you're going to present in your test question with petechiae. And then lupus is an inflammation of what we call mucosal or serosal surfaces. So you could have pericarditis, for example, which can lead to pericardial effusions and even pericardial tamponade. Remember, electrical alternans, narrow pulse pressure. Patients who have lupus can get endocardial inflammation. And this is where you get vegetations on both sides of the valve. And that's what we call Liebman-Sachs endocarditis. And then finally, patients can have abnormal chest x-rays with lupus such that they have blunting of the costophrenic ankle, and that refers to the pleural effusions. The renal manifestations of lupus can be either I'm peeing blood or I'm peeing protein. If I'm peeing protein and I'm a lupus patient, primarily protein if I'm peeing, you're going to be thinking of membranous nephropathy. The way I remember it is I am a member of the lupus community. So membranous nephropathy, in which you have basement membrane deposits of antigen antibody. Remember, type 3 hypersensitivity. And then your basement membrane ends up freaking out. And Pathoma does a great job with this, in which then you have a spike and dome, a spike and dome, a spike and dome. And that is going to refer to the mesangial and basement membrane proliferation you get with membranous nephropathy. The nephritic syndrome related to lupus is going to be what we call diffuse proliferative glomerulonephritis, which on electron microscopy shows these friable wire looping capillaries on your glomerular biopsy. Another integration for us to go through is this one. A 50-year-old male presents with a urine analysis significant for red blood cells. He has been having fever, weight loss, and fatigue over the past 3 months, so constitutional symptoms. 2 weeks prior, he was admitted for cough with bloody secretions. What do you think is the likely diagnosis here? So I kind of jumped from nephritic syndrome to tell you, ooh, here is a UA that is also suggesting a nephritic condition. And now this patient also has hemoptysis. And so we're worried about Goodpasture syndrome. or anti-glomerular basement membrane antibody disease. This is a classic, what we call hemoptysis hematuria syndrome. So what is the likely mechanism here? Well, remember that this is a type 2 hypersensitivity reaction to the glomerular basement membrane, which is type 4 collagen, which affects both the lung, causing hemoptysis, and the kidney, which causes hematuria. Now, over the next few months, the same patient presents with very bad kidney function and increasing BUN and creatinine. He is scheduled for renal biopsy. What is it likely going to show? And so you recognize that patients who have, for example, this pauciimmune glomerulonephritis, or what we call this anti-GBM antibody disease, Goodpasture syndrome, they can get what we call rapidly progressive crescenteric glomerulonephritis. And these crescents are going to be made up of two things, fibrin and macrophages. So RPGN, rapidly progressive glomerulonephritis, is going to be a spectrum of disease. You can have lupus and have diffuse proliferative glomerulonephritis that then progresses in your exam question to rapidly progressive crescenteric glomerulonephritis. Same thing with Goodpasture syndrome, as well as other hemoptysis and hematuria syndromes. So what I want you to recognize is that I have, in my past reviews, I have integrated a lot of these syndromes together. And I've published on all of the organ systems relevant for your NBME and USMLE exam. Over 20,000 students have viewed each of these videos. And I have now published them into a book that you can buy on Amazon, get it shipped directly to you, or read it on your Kindle as well, such that you have a free set of videos that you can follow along with the physical copy book, and you can watch the lectures, make notes, and annotate this high-yield pseudo first aid book. And so I encourage you to check out my High Guru notes. They are right now on Amazon. They're even on my website. You just got to type in High Guru NBME notes. And this book will really help you get through all of my videos and will help augment your NBME and USMLE scores. And so that brings me to the last syndrome. This is the syndrome around Halloween time, very spooky. This syndrome you don't want, this last syndrome that I'm going to be talking about. And that is the FOMO syndrome. I don't want you to miss out next weekend. I want you to be with me, integrating, synthesizing, going through these high yield videos and lectures with me. Next weekend, I'm going to be going through some top concepts in biochemistry. I'm going to link that right again. And please, please make sure you sign up for this course. And if you have any questions, I'd be more than happy to go through them. And especially if you have any reservations of the course as well. I look forward to seeing you within the next week. Next weekend is going to be a jam-packed session. We have so many students already joining, and I want you to be a part of that. And most importantly, for supporting me through this whole journey thus far, I want to say thank you so much. I really encourage you, because I don't spend a single dime on marketing. I do it all on my own. I want you to connect with me, share all of these lectures, all of this content on YouTube, Reddit, Instagram, Facebook, etc. Stay in touch with me via email. If you want to be entered in our raffles that we do bi-weekly, please make sure you write a review on our Trustpilot page, because this is the best way to get the word out. This integrative live lecture style review in a high energy, active recall manner. This is what makes learning so, so fun. And so with that, I'm going to conclude today. I'm going to stick around for any questions. But before you leave, please put down one thing that you learned from today's syndrome webinar, and then feel free to leave. Thank you so much. And I'll see you hopefully next weekend. All right. Excellent. Thank you, guys.